In this next section, we will review an approach to weaning. First and foremost, every patient on the ventilator requires a daily assessment to see if by chance today is a day that the patient might be successfully weaned. Is the reason that the patient got intubated now resolved? Are they not excessively sedated? Are there no new intercurrent problems? Is the patient not traveling for a procedure imminently? If the patient is hemodynamically stable on a modest FiO2 and PEEP level with an acceptable mental status, each of those patients should be assessed for extubation on a daily basis. There are a number of parameters which are utilized to assess a patient's potential for weaning. The two that have been evaluated most thoroughly and are used most widely today are the RSBI, or Rapid Shallow Breathing Index, and the NIF, the Negative Inspiratory Force. The patient's spontaneous respiratory rate is divided by their tidal volume in liters. If that ratio is less than 100, it predicts successful extubation. In measuring the negative inspiratory force, or more accurately, maximum inspiratory pressure, the patient is asked to breathe in against a closed endotracheal tube to which a pressure gauge has been applied. Any normal individual would be able to generate substantially negative intrathoracic pressures approaching negative 100 centimeters of water or more. Patients with severe neurologic weakness may be only capable of generating a few centimeters of water pressure. If the patient's maximum inspiratory pressure, or maximum negative inspiratory force, is less negative than minus 20 centimeters of water, it predicts failure to wean. It should be noted that the RSBI was first reported in the New England Journal of Medicine in 1991 by our own Drs. Yang and Tobin. If the patient's weaning parameters are anywhere close to acceptable, we will move on to a weaning trial. Weaning trial can be done in different ways, but our data would suggest that the most efficient way is through utilization of a T-piece trial. In another landmark article by Dr. Tobin in the New England Journal in 1995, 4 modes of mechanical ventilation were compared. And in this trial, one can see that once or twice daily T-piece trials had a much higher probability of successful weaning than did pressure support trials or IMV trials. When you look at the average patient randomized to IMV weaning trials, 5 days were required for successful extubation compared to 4 days for pressure support ventilatory trials, but only 3 days for daily or twice daily T-piece trials. And when one looks at the hardest to wean quartile, these differences are even more dramatic, with T-piece trials leading to successful extubation close to a week earlier than other approaches to mechanical ventilation. Finally, if the patient's T-piece trial is successful, one will move on to a trial of extubation, with this terminology emphasizing the fact that even in the best of circumstances, some patients will require reintubation within 24 hours of extubation. So some general rules of mechanical ventilation might be summarized by saying that the indications for intubation are assessed best by the look of that patient who is going to die otherwise. The goal of mechanical ventilation is to rest the patient and get rid of that look. We'd like to keep the pressures low to minimize the risk of barotrauma and not worry about the PCO2, a concept of permissive hypercapnia, which we will review shortly. And please keep an eye on the patient.